Someone did the recording, started? Mohssine?
Yeah.
I did.
Okay, good. So good evening, everybody. Namaste and Sat Sri Akal, Assalamu Alaikum. And we are here back again for the third session of webinar series presented by Sahaj Dental Academy. And today I'm going to present Dr. Mohssine, who is a DDS, and he has done his post-graduation in Periodontology, and he's a diplomat of WOPS, South Korea, and he's the founder president of IAIOS Academy in France. And he's a very good friend of mine, and he is an excellent implantologist and periodontologist, and has wonderful work. He has lectured all around the world. And without delay, because we have already been, because of the technical issues which we face these days because of heavy load on internet services, everybody is doing horde of webinars. So we were unable to go live on the Facebook, but this session is going to be recorded, and we will upload it on the YouTube channel of Sahaj Dental Academy, and then it'll be in front of everybody. So I welcome all the participants who are in here, and I am going to ask now Dr. Mohssine to start the presentation.
Thank you, my friend Sandeep. I'm happy to be with you today, and I hope that you are well in your home and you are safe and in good health, inshallah. So I am happy to share with you my experience about sinus lifting, and especially with the HPISE technique from Professor Sohn. As you know, when you lose your teeth in a posterior maxilla, you have a big bone loss in the posterior maxilla and the pneumatization of the sinus. Now, so when we want to give a fixed rehabilitation of this area, you have to graft this sinus and put our implant in the second stage if we have a big bone loss. Many practitioners don't want to touch in this area. They prefer to use another technique like pterygium technique or plates over the sinus. But I know that we can work in the sinus because we have good results with the grafting of the sinus. We have many years with this technique, and we can do put implants in this area easily. First of all, when we want to get a surgery in this area, we have to know precisely our anatomy and what happened in this zone, which arteria passed through this sinus, which is much important for us to work with this artery. As you know, the sinus is vascularized by internal maxillary arteria, especially with the alveolo-antral arteria. You see in this picture what's the path of this arteria through the wall of the sinus. And you see here in these pictures what happened. You know what's the beginning of this arteria and there was the end. And it passed in the vestibular wall of the sinus. This is here the alveolo-arterial arteria. When you want to give surgery in the sinus, you give sinus lifting, you have to know where is the situation of this arteria in the wall. Sometimes you have this arteria in position, in high position of the wall, and sometimes you have in the middle of the wall, and in other times you can see this arteria in the low position of the wall. That's you give you an indication to how to give windows on this wall to give access in your sinus. But sometimes we can have many ramifications of these arteria. You can see here in this X-ray that you have two ramifications on the wall. Donc, you have to pay attention when you start to create windows to don't cut these arteria. You can see here in these X-rays, you can have only one arteria in the wall, or two ramifications, or more than two ramifications. You see here in this picture that we create the windows to have access to your sinus. You have to see these arteria glow on the Schneiderian membrane in the left picture, and you can individualize this arteria when you elevate the membrane. Now you can pay attention when you elevate the membrane, you lift your membrane to don't cut this arteria, because the surgery will be bleeding. As you can see in this video, when you create your windows, you can cut this arteria, and you can have a bleeding surgery. So you have to stop bleeding before continuing the surgery. Now you can see here what happened. When you start to create a windows, it's very bleeding. But don't worry, you can continue your surgery. You have to stop bleeding with clamping the arteria in upstream, or to put your bone wax on the arteria that stops the bleeding, and you can continue your surgery to safety. Sometimes you have many cavities in the sinus, and you have to work with these cavities. Sometimes you have closed cavities, or many communication between cavities, and you have to, when you want to lift your membrane, you can to lift all the membrane in all the cavities to avoid to perform this Schneiderian membrane, and you can fill your sinus easily. You can see here in this picture that we have communication between cavities into the sinus, and when we have to fill your cavity, you have to lift your membrane in all of the cavities in the sinus. Now, we have, before beginning the surgery, we have to know what happened with Schneiderian membrane, what in the Schneiderian membrane, and what happened in the sinus when you want to give a sinus lifting. As you know, we have, our sinus is lined by this Schneiderian membrane, and when you begin to lift your Schneiderian membrane, you stop the osteoclasic process and you restart the osteogenic process. This is the more important thing that you have to know when you begin to elevate your membrane. In the moment that you elevate the membrane, some process to begin to start in the surgery. First of all, you have a blood clot formation and conjunctivovascular birth into the seat, and we start a new regeneration bone in the seat at the moment you elevate this membrane. In literature, you can see this, that the surgical treatment of loss of fresh or old bone substance, it was either the osteoconductive property of the bone and osteoinductive property, and finally on board. So you, with the bone tissue, can indeed by osteoconduction gradually rehabilitation natural or artificial frame, provided that surrounded by living that is well vasculated in compressive stresses. The rehabilitation is done by colonization from the banks in the cavity like sinus, as we know, and the junction in case of the segment bone substances. In the seat of surgery, we have many substances that help the new regeneration of the bone in the sinus. Specifically, you have the growth factors. Those growth factors are protein regulating cells division and differentiation. They play an important role in osteogenesis and osteoclastogenesis. And we are interested from 19 years for osteoinductive effect of this protein, which more recently has been associated with biomaterial in order to facilitate bone regeneration. This combination would allow gradual release of them growth factors, an acceleration of healing and regeneration. And the mineral phase then play the role of weft of scaffolding, allowing the three-dimensional sculpture of a newly formed bone. And growth factor will induce the differentiation of mesenchymal cells into osteoblasts. And the osteoblast will synthesize collagen type 1 and initiate osteogenesis. And you can say that the bone formation is therefore possible from the blood clots. Between growth factor that we have into the bone, we can have this BMP protein. It induces bone tissue beginning of differentiation of progenitor under the action of more or less specific growth factor. This osteoinductive protein is BMP. We can have it in the market now from synthesized BMP. It's osteoinductive growth factor produced by particular by osteoblast, and this protein acts by recruiting osteoprogenitor cells at the seat of bone formation. And when we want to have a story of the sinus lifting, we can say that in 1996, in a consensus conference in Boston, they called the sinus lifting a sinus bone graft. But with recent scientific knowledge, we can't give this name for the sinus lifting, the sinus bone graft, because we can say now the sinus filling is therefore not systematic, because the remodeling of the new regenerated bone into the sinus, it doesn't come from the graft, but it comes from the walls of the sinus and from the blood clot formation into the sinus. And in this case, a biomaterial can be used as a spacer. It does maintain the Schneiderian membrane in high position. And the lifting of the membrane induces the formation of blood clot in an enclosed space delimited in large parts by bone walls. And with the cellular exclusion, the clot can be the seat of bone regeneration from peripheral walls. These material or biomaterial will have many qualities to give a good result of a new regeneration of the bone into the sinus. It's this spacer method should we use can be have to maintain mechanically the membrane in the high position and to allow three-dimensional stabilization of the blood clot and allow osteogenic progression, the osteoconduction, and finally to prevent the re-expansion of the sinus and accelerate the speed and quality of regeneration bone. Now, we have to fill our sinus and we have to know which kind of material or biomaterial we want to have to fill our sinus. In the literature, we can see the gold standard bone that you have, it's the autologous bone. You can have this bone from the shin, of the ramic bone, of the hip bone, of the parietal bone. But in my experience, I don't use this bone for my sinus lifting augmentation because I have to have another seat, another surgical seat to remove the bone and to put it in the sinus. And I don't want to have more morbidity in the second set of surgery. So I don't use this autologous bone into my sinus, and especially I don't want to use the parietal bone, especially because it's risky for the patient to remove his parietal bone, and we risk to create many problems in post-operative time. I use frequently the xenograft bone, and especially the bio-os, the bovine bone, because I have from 25 years experience, I have a good result with this xenograft bone. You can use also a porcine bone, or you can use the aching bone or allograft bone. And sometimes in my surgeries, I mix between the allograft bone and the xenograft bone for having a good volume of bone to fill my sinus, and for having a good osteoconduction of the new regeneration of the bone into the sinus. I use frequently the powder of allograft bone. We can also use the synthetic bone, but I don't use it in the sinuses. I only give this my surgeries with the synthetic bone in a small bone loss around implant, or in the small defect in the jaw, the maxilla. But in sinus, I avoid to utilize this synthetic bone because I have more good result with xenograft bone mixing with the allograft. You can also use the autofoot bone graft powder mixing with the xenograft, and you have a good success of your surgery. You mix it with your PRF. You take a blood sample and you centrifugate it with a special protocol, and you can have growth factor and stem cells, and you have PRF, platelet-rich fibrin. In the market, you can see that you have IPRF, EPRF, EPRF plus, but in my mind, I think that it's similar to use IPRF in the sinus, because I have the same result. I have a protocol to centrifugate my blood, and I take the PRF and I mix it with my bone, my xenograft bone, and I have a miniaturized plasmatic matrix. Or it's the using of MPM and growth factors significantly improved and facilitate bone graft in general, and in particular the increase in sinus volume. There's NPM you can see in the literature. There's NPM, we can call it sticky bone. We can call it a bone graft. In my mind, I think that it's the same, it's the same, and it's the key of success of modern bone grafting. Now, let me show you a comparative study between the different material used in sinusoidal filling. This study was took by Gitlich, and you can see in this graphic what the implant survival rate of the implant survival rate when you use a kind of biomaterial. As you see in this graphic, when you use xenograft bone, you have 95% of success of stabilization of your implant into the graft against 92% when you use only autologous bone, and 81% when you use the synthetic bone. And what's the behavior remodeling? What happened with the xenograft bone into your sinus when you put it in the sinus? When you take X-ray after 10 years or after 20 months, etc. You can see here the transformation of your xenograft in your formed bone after 10 years of filling. You can see that the transformation is for 86% of new formed bone against 13% of bios. You can see here the histophotometric analysis of the new regeneration bone in the site of grafting. The new bone is regenerated here around the particle of bios. And you can also see the formation of osteoid and osteoblast. Now, we are in front of our patient. We study our CBCT, and we want to give a surgery in our sinus, and we have to give sinus lifting. Which approach that you have to done for having a good result of our surgery? In sinus lifting, we have only two techniques. Especially two techniques, a lateral approach or a crystal approach. As you know, the lateral approach, we use it from 30 years. I use this technique from 25 years. And as you know, this technique is invasive technique, and the post-operative consequences are very hard. we used in 20 years before mechanic system to remove the wall of the bone to have access on our sinus, and we had in these times 70% of perforations. We can't give, in general, we can't give our sinus lifting in one surgery. We had to stop our surgery many times for 3 or 4 weeks, and we restart surgery after 4 weeks, and we can give our sinus lifting, and we had as afraid to have perforation because we don't have experience with these mechanical techniques. And now you are very lucky to have a piezo-surgery in your practice, because that resolves many problems of perforation and many problems of bleeding around the sinus. These advantages of piezo-surgery are to reduce bleeding in the site of the surgery, and they reduce Schneiderian membrane tear, and it protects the flap when you do a piezo surgery. You have many instruments to use when you want to give a lateral approach in your sinus lifting. In the market, you can have many instruments, many tips. In Europe, we use tips from Action or from Metro. In my clinic, I use specially Metro tips. You can have in India or in Asia other tips. It's the same. The most important thing that you have to elevate the membrane with serenity, and you don't to perforate your membrane. When you create the windows, you can elevate your windows, and you can fill your sinus. You can also to remove the bone. You can remove the bone before filling the sinus, and you can also take this bone into the sinus as scaffolding to protect your membrane from the bone graft. You can use this instrument to elevate your membrane. And as you know, everybody knows that this technique of lateral approach of sinus lifting, it's used in the world for 90% of the practitioner. But when I want to show you the Prof Sohn technique, I am sure that you are going to use this technique in the maximum of your surgeries, because it's so easier to use the HPISE technique against the lateral approach. You can see here that you can open your windows, and you can elevate your membrane with mechanical instrument or a piezo-surgery instrument, and you can individualize the arteria and put your bone into the sinus. Let's see now few X-rays for this technique, the lateral approach of this technique. In this patient, we had to give a sinus lifting and put implants. You can see after 5 years that what happened around the implant, what is the osteoconduction rule of the body os around the implant and the new regeneration bone after 5 years. You can see here also in these X-rays. Now, after this, we have already used this technique, a lateral approach, but I learned the HPISE technique from 7 years from Professor Dong, and I see many publications of this technique. I want to be sincere with you. I use this technique for 95% of my sinus lifting surgeries. I avoid to use the lateral approach when I learn this technique because I have no much post-operative discomfort. We can use many tips for this technique. As I said before, you can have on the market many kind of tips in Asia, or Europe, or USA, but in general, we have to go to have in our material a good instrument to have a good practice. In my clinic, I use a metronome for this HPISE technique. And I want to give you what is the HPISE technique. It's called Hydrodynamic Piezoelectric internal sinus elevation. These techniques can be applied to maxillary sinus augmentation. It results in favorable success rate with minimal postoperative discomfort and a high level of predictability. It requires minimal instrumentation. The HPISE technique may be an alternative to the lateral approach of sinus augmentation because the Schneiderian membrane elevation is similar to that performed in laterally approach. And a most important thing that what we want in your clinic, in our clinics, that the patients said, okay, I want to have this surgery. Because as you know, all our patients, when you propose the surgery, they go to internet and they read what happened with the surgery. And they come in our clinics. They are afraid to go to the surgery. Doctor, I am afraid. I don't want to give this surgery. It's the post-operative discomfort is very high, and I don't want to have blood, and I don't want to have problems with my sinus. You can say then that with this HPISE technique, we don't have these problems because you can have a minimum of discomfort, You are sure that when you practice this technique on your patients, you are very happy. They don't have problems after the surgery. A study was done by Professor Dong and team for this technique. It consists to 215 sinus elevation, unilateral or bilateral elevation performed in completely edontless or partially edontless patients. The study was done on men and women and different ages. And they place 353 implants with the HPISE technique with augmentation of the sinus with different kind of and different system of implants and different length and different diameters, and with the bone grafting and without bone grafting, and they control the evolution of the sinus augmentation for 69 weeks. And they have this conclusion. They had 10 membrane perforation with the recorded on 353 implant lab, the rate is 2.83%, and the success rate is for 1970% after 69 weeks of care. This is the result. When I saw this result, I thought to myself, this is the technique. I have to do this technique in all my patients. I gave this technique because this technique is sure and it's very simple to use by practitioner. Let's know now which kind of surgery you can give when you have to give a sinus lifting. In literature, you can read that you have to give a lateral approach when you have less than 3 millimeters of residual bone. And when you have more than 3 millimeters, you can also use the crystal approach. The most important thing that you have to know, you can use this technique or other technique when you are sure with your technique. In my practice now, I give the HPISE technique even if I have less than 3 millimeters. It's my practice. But in the literature, you have to read that you have to do the lateral approach when you have less than 3 millimeters. So you in the literature, you can see that you can have you can give HPISE technique or crystal approach when you have more than 3 millimeters of residual bone. You can also use a bone grafting or not bone grafting in the techniques. In general, when you have less than 3 millimeters of residual bone, you give a bone grafting. And in my practice, when I have a primary stability of my implant, I put my implant in the same stage. But when I am not sure to have stability, I give the bone grafting surgery in the first stage, and I wait 4 or 6 months to give second stage of surgery, and I put my implant in the second stage. So, but sometimes you have the extreme cases, and you have to fill your sinuses before placing implant if you want to have a fixed rehabilitation. So you fill your sinuses 6 months, and you have to wait 6 months before placing your implant. So let's see now a few cases for this HPISE technique and rehabilitation. In this case, you can see that this patient is going to lose his molar. You have to extract it, and we can't put implant in the same stage because you have to clean the area, and we have to create bone around in the seat before implanting, because we don't have primary stability of our implant. So we practice this HPISE technique, and first time we graft the seat, and we wait 6 months before implanting. You can see here we don't have primary stability, and we create the volume of bone, and we implant we place the implant in a second stage. In this case, we have 4 millimeters of residual bone. It's an ideal case to practice HPISE technique with serenity, without problem. You can see here that you have residual bone, 4 millimeters, and when you do your HPISE technique, you can elevate your membrane easily until 15 millimeters, and you put your CGF, your PLF, and if you want to put your bone graft in the same time and your implant in the same stage, you can do it. Look at this X-ray. We have 15 millimeters of elevation. We put our CGF into the sinus, and in this case, I don't put bone grafting. I put only my implant with CGF, and this is the result after few months. Now we have to learn how to practice this HPISE technique step by step. When you study your CBCT and you know that you have few millimeters under the floor of the sinus, you have, for example, you have 4 millimeters of residual bone. You have to drill the bone to 3 millimeters and you stop drilling. You let 1 millimeter of residual bone against the floor of the sinus, and you change the tips, and you use the piezoelectric tips, and you remove the residual bone against the membrane, and you have sensation that you have in proximity of your membrane. You use this instrument and you remove gradually your bone to have a proximity of your Schneiderian membrane. You use this tip to give a pressure into the hole of your sinus. This pressure, you can regulate it gradually, and you don't have to have a big pressure into the sinus. You risk to perform your Schneiderian membrane. So you go gradually with the pressure, and you elevate your membrane step by step, gradually. And after you elevate your membrane, you can control that if you have performed your Schneiderian membrane or not with Valsalva technique. When you do the Valsalva technique, you see through the hole that the Schneiderian membrane is in movement, and we sometimes you hear your patient say to you, "Oh, doctor, I have some water in my throat." In this moment, you know you have performed your Schneiderian membrane. This is the question. Are we stop our surgery in these circumstances or not? I never stop my surgery in this circumstance, but I know that I have to put a maximum of PRF and CGF into my sinus, and I avoid to put bone grafting if I know that I perform my sinus. So if we have less than 3 millimeters of residual bone, and we practice this technique, and we perform our membrane, we have no other solution than to give a lateral approach, because we want to graft, because we don't have enough bone into the sinus to place an implant in the second stage. If you have this problem with this technique, and you perform your membrane, and you have to put implant to put bone graft into the sinus, you have to give windows and elevate your membrane, and you elevate quickly your membrane, and you don't have to have a big perforation into the sinus, into the membrane, and you have to glue a collagen membrane against your Schneiderian membrane, and to put your bone graft before closing your sinus. If you don't perform your Schneiderian membrane, you can continue to put a PRF and CGF and eventually the bone grafting into the sinus, and you put your implant in the same stage. Now, in this case, you can see that you have a plast implant in the same stage without bone grafting, and you stop the osteoclasic process. And we took X-ray after 45 days, and you can see here in the X-ray that you are starting a bone regeneration. Now you can see here in panoramic X-ray that you have a new bone regeneration around your implant. And you can see here the case finished, and this is the pictures after 5 years. Now let's see what happened after 5 years with HPISE technique and bone grafting. You can see here the preoperative X-rays and the post-operative X-rays, and you can appreciate here with the effect of the osteoconductive effect of the bio-os into the sinus. You can see the volume of the new regenerated bone into the sinus in post-operative X-rays. This is a patient that I done a surgery with bone grafting with HPISE technique, and I see this healing after a few months, and we gave the same surgery without bone grafting in another case, and you can see that we have the same result. You can see here without bone grafting, and the position of our implant and the osteoconduction and the creation of the bone around our implant. And in the second X-ray, you can see the new regeneration bone around the implant with the bone grafting. In this case, I wanted to give a sinus lifting with bone grafting in the side right, and I gave sinus lifting without bone graft in the left side. So we have the result after 5 years, and you can see that you have the same result. In this case, we have only 5 millimeters of residual bone, and we have to create to implant this area and you planificate this surgery, and we can say in panoramics that we have two cavities into the sinus, and we give the HPISE technique, and we as you see in this panoramic X-ray that we have 18 millimeters of height of the elevation of the sphenoidal membrane. You can also see in the second cavity that you have also an elevation of the membrane. We put the implant in the same stage without bone grafting. You can see here. And this is the case finisher. In this case, we have the same stage. In the right side, we gave HPISE technique without bone grafting. And the left side, we gave the HPISE technique with bone grafting in the second implant only. You can see here with CBCT what happened in the right side and what has happened in the left side. And this is the case finished after a few years. In this case also, you can see that you can give a specific technique and you can have primary stability of your implant, and you can put your implant in the same stage without problem. This is the case after a few years. You can see that the patient not brush his teeth. In this case, I gave a HPISE technique in the right side, and you can see the healing of the sinus, and you can't have problems with this HPISE technique in this case. And you planificate another surgery in the left side with HPISE technique also. You can say here what happened when we put our 3 implants and with this HPISE technique. This is the healing of the gum, and the crown are placed after a few months. Let's see now a video for this technique, and you can ask questions about this video.
Mohssine, thank you. A wonderful. I think we will ask the question once we finish with the presentation.
What do you say?
I'm saying that let us start the question answer session once you finish the presentation.
Okay, we continue the lecture.
Yes.
You can see here the residual bone.
You can keep on explaining them that how you are, in this video, how you are performing and what you are doing, which what are all those instruments, the piezo tips which you have to use. Just like in this, you're using a diamond tip. Can you hear me? Hello? Am I audible to you? Dr. Mohssine?
Yeah.
Yeah, you can tell them that which tips you are using right now.
You want to stop the video?
No. I'm asking that you need to tell them what are all those tips which you are the piezo.
Steps is action steps.
Okay. So the first one was a diamond coated tip for initial osteotomy.
I don't hear you very well. We have to finish the video, and you can ask your question, Sandeep, because you have the music here, and I don't hear you very nice. In the second molar, you can see that I have to drill my bone before using my tips. In this case, I used another kind of tips for action tips. You see here what happened into the sinus. We use the pressure into the hole of the sinus, and we push the membrane and you elevate it. You introduce the PRF and CGF into the sinus, and we don't give a bone grafting into the sinus. You see here the position of our implant and the height of Schneiderian membrane. You see the primary stability of our implant in this stage. And I gave the bone grafting in the vestibular side because we don't have enough bone for aesthetic healing. This is the X-ray in post-operative X-ray. So I take this X-ray 6 months after, and we can see the new regeneration bone between our implant and the stability of our implant 6 months later. Then I can see the healing of the sinus and the bone regeneration around our implant. The question is why I put my implant in the same stage of my elevation, of sinus elevation, even if I have less than 3 millimeters of residual bone. The response is, the answer is because the form of my sinus can give me the possibility that I have enough walls to fix my implant and to have a primary stability. You can see it in the X-ray in the right side. This is the X-ray after a few months and the healing after a few months. We test our stability, the stability of our implant. You can see here 71 and 75 ISQ. We can load our implant. We put to our pillar and we finish our case. So ultimately, the biological mechanism involved in sinus floor elevation surgeries are understood now. Only the presence of blood clot stable over the time is required to create a bone under the sinus membrane, and the ossification of this clot is done concentrically from the bone walls in intramaxillary cavity. The introduction of autologous bone or biomaterial in this space under the sinus will have an osteoconductor role in bone promotion, and it maintains the three-dimensional stability of the clot against intrasinusal pressure. Let's see now a surgery done by Professor Sohn for this technique, and we can see the mobility of the Schneiderian membrane through the hole and before implanting. This is another kind of tips that Professor Sohn used in his surgeries. You can see through the hole the movement of the Schneiderian membrane. He put the bone grafting into the sinus because he was sure that he had not perforation in his membrane. In conclusion, The HPC technique revolutionized the maxillary sinus augmentation, and it resulted in favorable success rate, minimal post-operative discomfort, and a high level of predictability. This increased a minimal instrumentation, and it's become an effective alternative to the lateral approach because we get a sinus membrane elevation similar to the lateral approach. Thank you for kind attention.
Thank you so much for a wonderful presentation, Dr. Mohssine, and I believe that everybody enjoyed it. And now I will put some questions for you, which has been asked by the participants.
Yeah.
That how frequently, this is by Dr. Binod Chandra, that how frequently you do without grafts in HP's technique. I mean, when you are placing implants without, how frequently is your placements without grafts?
When I have more than 4 or 5 millimeters of residual bone, I frequently don't put bone grafting. I only put PLF and CGF because I have enough bone for primary stability of my bone, and with the blood clot and the new regeneration of the bone, I am sure after a few years I have a new formed bone around my implant, so I can put my implant without bone grafting.
Okay, there is a second question by a very good friend of mine, all of us, Vaibhav and Dr. Chakshwish, Dr. Danish Barmare from Mumbai, that how to confirm if there is a perforation.
It's, as I said before, when you elevate your membrane through the whole of your sinus, you do the Valsalva technique, and you see the movement of your Schneiderian membrane, as we saw with Professor Sohn. We see the movement of your Schneiderian membrane. And frequently, when you perform your Schneiderian membrane, the patient said you, I have water in my throat. Donc, so I have water. So you know that you have performed your Schneiderian membrane.
Yeah,
Because
now
when you don't perforate, the patient don't have water in his throat.
okay, okay. Now there are questions from. I'll be asking on behalf of the participants that how you decide that you have to go for a lateral approach or a crestal approach. So, what is the basic criteria which you follow when you're doing an HPs? Like, is the RBH is the basic criteria, the residual bone height?
Yeah, because I decide to give a lateral approach when I am sure that I don't have enough bone and the patient can support the surgery. In general, as I said, when I have less than 3 millimeters of residual bone, I also give a sign HPC technique, and I put my graft through the whole of the HPC technique.
So, do you think that this HP's technique is an alternative for a minimally invasive surgical protocol? I mean, like it is a minimally invasive surgical protocol. And then in this case, in most of the cases, if you see that lateral approach is the indication, but still without placing implant, without placing an implant, can you just like in two stages, in one of your cases, you showed us that you tried to place the graft material, and especially xenogenic graft
Yeah,
biomaterial, to lift and then leave it for 6 months and then do the re-entry. So is it the right approach if you have very little RBH?
yeah. When I don't have another alternative, I do this technique because we don't have any other solution for the patient to rehabilitate it in fixed rehabilitation.
Okay, another question is that since it is a closed technique and it is almost blind blind way to go inside the sinus, and there are certain micro perforations which can happen, which
Yeah.
you don't even come to know about.
Can you talk the micros? I don't have you.
You don't even come to know about this perforation,
Huh?
uh, even in the bellowing. When the bellowing is there, when you do the Valsalva technique, certain times there are micro perforations which, when you ask the patient to blow, breathe in, breathe out,
Yeah,
there are chances of getting a micro perforation.
yeah,
So in that case, what you prefer? First you try to uh, place a IPRF kind of thing, or the CGF first, so that it seals the Schneiderian membrane, and
yeah.
and then you place the graft, or you just prefer placing the CGF and get a tenting effect by placing an implant. Because as you go by Boozer et al. And most of the people all around the world, they say that the minimum length of an implant should
Uh-huh.
be 10 millimeter.
Yeah,
Shorter implant is not an idea for them.
yeah.
Yeah.
Okay. And when I have a micro perforations, as you know, when you put the CGF or a PLF into the sinus, you have a healing of the membrane after a few days. So you can also put your bone grafting with your MPM or sticky bone, because the PRF unload the bone, and in the time of healing, the Schneider membrane is held too. Now you don't have the bone in the nose.
Okay. One more question, that the one of the biggest criteria, that whether you have to go for lateral approach or crestal approach, you need to look into the pathologies. So if
Yeah,
there is a mucocele, or there is some kind of pathology inside,
yeah,
because Schneiderian membrane is not very thick mostly.
yeah,
And when we see, because recently we were watching Dr. Michael Pecos,
yeah.
and he said that all those pathologies can make that Schneiderian membrane look thick, but it
Yeah.
is not a good idea to do that until unless you remove the pathologies.
Uh-huh.
So what
Uh,
do you think about the pathologies? Because this technique is very blind procedure.
yeah, the HPC technique. In my experience, I do this taking the HPC technique with pathologies into the sinus, especially with the mucocell or the kind of this technique, because you have the the height of the Schneider membrane is very thick, and I can't push it easily. I don't. I am sure I can. I am not going to perforate, and we don't have disease after the surgery in general. We can see many video of Professor Don with this HPC technique, and this is into the sinus. He also put his implant and he elevate his sinus with this technique with mucosal too.
Okay.
But
Okay.
if we have a big pathology and we have risk to perform the Schneiderian membrane or to have not good consequences after the surgery, we don't practice it. We can give advice to have a good sinus before surgery.
Yeah, my idea was asking this question that all those who wants to practice this HP's technique, the first thing is that they need to be well aware with the piezo surgeries,
Yeah.
and piezo surgery is a fantastic armamentarium to be included in our practice. And when I went to Busan, I got this Sohn tips specifically for this HP's technique. And
Yeah.
it was a gift from, I call him master, so it was a gift from him to me, and I became the first user in India. But the thing is that you have to be, for each and every case, I believe that the case selection and planning is very important.
Mm-hmm.
Now I have one more question for you, that what about when we see the floor with an acute angle?
The
Uh,
cute, I don't
yeah,
understand it.
yeah. I'm going on to. Can you can you stop sharing the screen so that I can
Yeah.
yeah, share? Go on to the whiteboard. Uh, yes. We are onto the whiteboard. So if you see something like this, that imagine this is a floor,
Uh-huh.
and this is the residual bone height,
Mm-hmm.
and we have a tooth here. There's a missing tooth here.
You draw it very well.
So now when we have to create a hole here,
Yeah.
look at this floor. The floor is not in an acute angle,
Uh-huh.
but sometimes it happens that the floor dips in and it has this kind of angle.
Yeah.
And in that case, there is a bone now here, and the tooth is here. There's a bone here, and the tooth is just imagine into the premolar region.
Yeah.
Now, if you want to go for HP's technique into this kind of situation, there is
Mm-hmm.
always a chance of tear,
Yeah.
because the is uh, angle is acute angle.
Uh-huh. Yes.
So, would you like to advise the floor of sinus?
Mm-hmm.
So, in this acute angle situation,
Uh-huh.
would you like to go for a HP's technique or not? Because
Yeah.
then it is always a chance of perforation. There's
Yeah.
always a,
But when you use you regulate your pressure to elevate the membrane, you have more chance to don't perform the Schneiderian membrane. If you give a lateral approach, you have the same problems because you have an angle too, and you have sometimes much problems with your instrument to elevate the membrane in this angle with the mechanical instrument or piezo instrument into the sinus. But with pressure, you can have less than problems, I think. But
Okay.
I use HPISE technique in this case. I have to regulate the pressure into my tip to elevate gradually my membrane.
Okay, you mean to say that everything needs, the first and the foremost thing is that everybody has to learn the procedure. That's very
Yeah,
to have an expertise. So you need to attend the courses, and you need to go and learn it, and then come back and then try to on your patient.
it's when you see that the surgeries, you can't say that it's uh, easy in general, but you
Yeah,
have to learn before. You have to learn before the technique. You have to study your CBCT. You have to give a protocol, and you have to have experience with your material before using it on patients in every
yeah,
technique. Even if you use the lateral technique or the crystal technique or another other technique on the teeth or on the bone, on everywhere, you have to learn and have expertise to practice the technique.
yeah. One more thing I would like to ask about the when you use a graft material for sinus, do you have any preference for particle size? Would you like to do a small particle or large particle graft?
In sinus, I use small particles because I don't want to have a problem in postoperative because the bigger particles will when the patient comes to eat. I don't want to have problems with bigger particles against the membrane.
Okay,
Yeah? So I use frequently the small particles.
okay.
Uh,
So your preference of um biomaterial is xenogenic graft or
yeah, yeah,
uh,
dios.
porcine or allograft or a
Yeah,
putty material or synthetic graft?
yeah. As I saw before, I use xenografts both in 19 or 95% of my cases, and the bio especially the bovine bone with a small particle,
Okay,
0.25 micron.
okay.
But uh, in sometimes I mix between a powder of allograft and bios to have much volume of bone into the sinus when I practice the lateral approach, and with the allograft we have a good osteoconduction to have a new regeneration bone.
Okay. Now, one more question comes in the practice, which I myself try to get an answer for that, is when we are doing a simultaneous approach, like we created the osteotomy, we lifted the membrane, and we placed growth factors first, and then we try to place, because I personally prefer using a putty kind of material or a sticky bone kind of thing, not directly any graft material,
Yeah.
rather in a sticky format. But when you are placing a xenograft and then simultaneously you are placing an implant, what what is the bone implant contact ratio? Because xenograph is osteoconductive. Definitely it is not going to integrate with the implant surface directly.
Uh-huh.
So when you place it, just like in as Boozer et al. Says, and as Kardaropoli uses and Istvan uses it, they when they are doing GBR, they
Uh-huh.
always say that use an autogenous bone first on the exposed surface of the implant, and then cover it with a biomaterial which is xenogenic or anything else. So,
Mm.
so the integration happens, and that bone resorbs the autogenous, and then a new bone formation is happening, and conversion is happening into the biomaterial which has been placed. But here we are doing it simultaneously. So I believe the bone implant contact ratio becomes less, and that is why people prefer lateral approach, wait for 6 to 8 months, and then place the implant so that there is a conversion.
Mhm.
What
Yeah.
do you what do you have to say about that?
Uh, I think that it's the experience of the practitioner. Uh, when we are sure with this technique or this technique, you can use it with serenity. I use HPC technique, as I said, 95% of my cases. Even if I have a little bone residual bone or a big residual bone, I I am sure with this technique, and I have stability, and I have a good result after a few years. So the contact between the bone and the implant will be reconstructed in a few years because, as I said, the bone clot formation is going to recreate the new formed bone around the implant, and you have to you are going to have resorption of the biomaterial after a few years. So in the first time, we have stability. If you you have stability if you practice the lateral approach or the of or the Ashkenazi technique or approach. That's stability. But the new bone regeneration will be there after a few years. I think that.
Okay, okay. So the last thing which I'm going to ask you is, and then we finish this session. And this is like when. What about the sagittal section? And everybody has to keep in mind that what is the buccal bone thickness of the lateral wall there, because if it is less, then as you show in one of your cases, you said that you did a GBR procedure also, just to increase the volume of the bone for later, because if it is less than 2 millimeter, then there are chances of bone loss on the buccal aspect.
Mhm.
So is it I mean, like, I believe that it is mandatory to combine a GBR procedure also side by side.
Yeah, yeah, okay.
So thank you so much. I would like to thank you for so much of your time and for wonderful presentation. And we were so it, upset about the live presentation was not there because it was we were unable to connect it. Though we tried to do that 2 days earlier, and it happened. But what we are going to do is we are going to upload this video on YouTube, and then can publish it onto Facebook. So thank you so much, and I would like to tell everybody here that Dr. Mohsin will be joining as a faculty for Sahaj Dental Academy very soon as a mentor, and we would like to bring him to India for a course once this COVID-19 situation goes away. So stay safe, stay back home, and let this lockdown period finish. And we have wonderful presentations tomorrow again. Professor Calvo from University of Murcia, Spain, is going to talk about this temporary implants. So when we give multiple implants, we have to rehabilitate patient for 6 months or 5 months or 4 months. So for that, he has developed one thing, temporary implants, which are fantastic. So he's going to talk about that. And another good news is that Dr. Joseph Khan is going to be with us for half an hour for a question answer session on tips and tricks on anterior aesthetic zone. So thank you so much, Dr. Mohsin. It was
See you
wonderful.
later.
Yeah, namaste.
Bye, everybody.
Yeah, ciao, ciao.
Ciao.
Thank you. Thank you so much, everybody. हाँ जी, कौन है यहाँ पे हम लोग? I would like to ask everybody to quit the meeting except my team here. So please